Morning, everybody.
Morning.
Thanks for being here today, especially those of you that do a lot of driving to come down here, and especially our members here that come down that are not part of DOH. We always appreciate having you here, getting your input, and participating in the meetings. And so today is the quarterly Mexico Department of Health Facilities and Los Lunas Community Program Governing Board meeting. We're here in Los Lunas Community Programs conference room. It's about 10 a.m. and usually our first order of business on the agenda is just to call to order and establish who's present, who's not here, and establish a quorum. So as I do each time, I'll just start with my right with our Cabinet Secretary, and we'll go around the room.
Greta Ward.
Gabrielle Sanchez-Sandoval.
Sean Helms, Los Lunas.
Lori Montgomery, New Mexico State Veterans Home.
Thank you.
Troy Jones, NMBHI.
Tim Hale, New Mexico Department of Veteran Services.
Jeremy Avarella, Fort Dare Medical Center.
Kathy Thompson, DOH.
Leonard Tapia, DOH.
Martha Gorman, Roswell Rehab.
Gino Rinaldi, Cabinet Secretary for Aging and Long-Term Services, and soon to be grandpa to little boy.
Congratulations.
Open your wallet.
And co-secretary.
Charles Riedel, Sequoia.
Shauna Hartley, Turquoise Lodge. Gail Nash, Chief Nursing Officer, Department of Health.
Steve Dorman, Chief Medical Officer, Department of Health.
Daphne Red Hopkins, Behavioral Health Director, Children, Youth and Families Department.
Brad McGrath, Chief Deputy Secretary. And Kathy, I believe we have a quorum today, so that's great. And I think maybe just as an item that we started to do last time, but I think, Marty, we didn't get a chance to really introduce you last time. Why don't you go ahead and we'll do that with both you and Shauna, and have you introduce yourself and tell people a little bit about your background.
Just quick and
As
down.
much as you like.
Well, my friends all call me Marty, so I got that nickname as a 6-year-old,
Yeah, we can get a spot for you.
7-year-old, something like that. So, but I answer to both. So, if Martha comes through, I think on the email, you'll know who it is. I've been in healthcare for quite some time. This is my first. Leonard and I were just talking about it. It's my first experience working for a governmental agency. I was married to a naval officer. I am married to a naval officer. He's retired, so I do have a little bit of background with what goes on in governmental agencies. But it's very exciting. Who would have thought at this stage in my life I would be going out on a new adventure for the third time. I think I've retired at least 3 times now.
Right.
So I'm from Virginia. My husband's from Connecticut. Eventually, we want to head back that way. We own property in Virginia, but we've been in Roswell. We've owned property in Roswell since 1997. But I only worked there once. I was recruited out to Roswell by an old colleague, a friend of mine, and I stayed there for 2 years, and then I ventured out. I retired from a large health system in Oklahoma, and did interim work all over the country, and spent the last 4 years in a little hospital in Alamogordo, New Mexico, as their chief nursing officer. So how I lasted 4 years down there, I'll never know, because my husband had to stay home and take care of all the critters. So, but we made it, and I'm just delighted to be at the rehab center, and we're already seeing progress. We're already seeing some of those wagons getting in the circle. So I feel very good about it, and I'm pleased to be here. And I'm sorry I was late last time. I didn't get introduced.
No, we appreciate having you there too with all that extensive background. I remember, I think you have a bachelor, I think, and a master's from Medical College of Virginia.
Virginia, yes.
Which is great. With all that nursing clinical background, that's going to be a big help to our team in Roswell.
Oh, definitely. I'm already seeing how I can be of help.
Okay. I know, I think I was saying the week of May 5th through 9th, Dr. Dorman and I'll probably both be there, I think, right?
Yep.
And Gail's going to be spending a lot of time there also. And we're, Lisa in HR is working aggressively with you on your vacancies.
We're doing well. I think you're seeing the reports.
Yep, so we're just working on, like everywhere, getting our census up. It's great having you there.
Thank you.
And also, Sean, I'll have you reintroduce yourself. Sean is already doing an incredible job at Turquoise Lodge. just started there, but why don't you tell people your background as well?
So my name is Shauna Hartley, and I'm originally from El Paso, Texas. I got my undergraduate degree at UTEP, Harvard on the border. My master's degree in San Antonio. I've worked with various populations. I'm a licensed independent social worker, so I've been a direct practitioner in addition to a program development person. I actually started my career here in New Mexico 18 years ago with children, youth, and families as a family preservation worker, and then I went into the nonprofit sector, and I worked for Valencia Counseling Services for approximately 15 years in various roles as the program director of the residential program, the clinical director of all 4 satellite clinics, and then I moved into their quality improvement director position when I left there, continuing part-time for 5 years. I worked with the University of New Mexico as a direct care provider with the Elevate program, and I've also had my own consulting business for approximately 5 years. So I came back to working with the state of New Mexico. I was working with Daphne's group with licensing and certification, and I've been very blessed with this opportunity. So I've been with Turquoise Lodge for the last 7 weeks. Feels like a longer time than that. And I think my background in working with both adults and kids is going to be helpful in improving the programming that we have there. So,
Right. No, you're doing a great job. You're off to a great start.
Thank you.
Especially, and I know in the adolescent unit, you're already making strides there, so greatly appreciate that. And the other change, Jeremy has officially accepted the Chief Facilities Officer position. He's just in a transition mode because first job he has to replace himself at Fort Bayard. So you have to have a licensed administrator.
Yes.
So we have to have somebody in place there. So, you know, as I'm traveling around the state, I'm sure we'll spend a lot of time traveling or doing things together, but one of our first goals will be to replace you at Fort Bayard, right?
I'll keep my fingers crossed. I'm told that that position's gone out to be posted, so then we can hopefully start aggressively posting that around about.
Right.
So look for some good candidates.
Great. So those are big changes. And great to have you here, and everybody that's back here today. And the first item we do, they were kind of routine, but the agenda is pretty standard each month, but the first item on there is the approval of the agenda for today. So I just ask for a motion to approve the agenda.
So move.
Second?
Second.
All in favor? Aye. Usually there's no one opposed, I'll say opposed. Okay. And then it takes a few minutes there, but back in January, we have several pages here that make up the minutes from our meeting at Turquoise Lodge in January, as well as the administrator reports from January, the financial report and the credentialing report. So there's quite a few pages there, but take a moment there where you can take a look at those.
I'll make a motion to approve the minutes.
Okay.
Second.
All in favor? Aye. Opposed? Thank you very much. And as we do each time, we start our new business with a report from our Cabinet Secretary, Red Ward.
Good morning, and thank you all for being here today. It's been a big week already. We had, Monday, we had the grand opening of Phase 2 of Meadows at MNBHI. Governor was there. We had some other dignitaries. It was a beautiful, beautiful day. Snow in the morning, sun in the afternoon. Nice crowd. Troy and his team did a fabulous job of organizing the event, and Governor Martinez was gracious and warm and stayed quite a while after the official ceremony to meet and greet not only residents but guests who had come. So it was a really special event. So I want to publicly thank Troy and his group for the great job they did in organizing that. And it was wonderful to be there. I want you to know that Brad, Lynn, and I will be visiting more this year. We've gotten a lot accomplished in the past year and filled some key positions, so we're going to be out on the road more this year. We're looking forward. I have not visited Lori in the Veterans Home, and that's going to be one of my top priorities, one of my first stops.
Perfect.
And I haven't been to Roswell, even though I grew up in Roswell, Marty, and was born there, and grew up in that area. Haven't visited your facility, but that's on my list for a top stop as well. And the three of us will be visiting you more often in the next year. And I also want to thank you for your excellent participation in the budget and HR meetings that we've implemented, the monthly meetings. It's making a difference in the progress that we're making, so thank you very much.
Thank you. And I think in my report, well, first I want to thank Secretary Hale for teaming up with us. I'm not sure how much of an uphill battle it is, but I know we're working on we're trying to do everything we can to
Put the heat on.
put the heat on with our project, which is so important to us at Veterans Home. Is there any comments that you want to make about that? Or?
Well, it's get one of the common things that we have to keep working with the VA is keeping them aware of how rural New Mexico is. They see our state population. They see one veterans home. They have no concept. Most of the members have no concept in DC what it takes to transport a family member to a place like Truth and Consequences, and how hard it is to keep a place out in Truth and Consequences at the level of care that we have there. It is so outstanding, but we are just going to keep the heat on to try and get that money flowing. As I go out over the next couple of months to work cemetery program issues, those offices are in the same building, so I'll be making visits on those.
And Laura, you want to make any comments too about
I
that?
have a couple things in my report that I could follow up on, so I'll just save it for that.
And I think we could probably raise a lot of money for the deficit if we put a pool in on when we think we'll get a letter back from the VA on our inquiry.
What year?
I know, right?
Yeah. So everybody
We could do a
knows.
lot
I
of
mean,
squares.
I think we were as high as number 2
Yeah,
on
it's
the
been,
project list,
it's been there.
and then it's kind of like I guess it's like a record. You're number 2 one week, and
Number 60 the next.
That's right.
Yeah,
you're
exactly.
bandstand,
Great.
it's number 60. Go ahead.
How are you basing the need? I mean, I understand the whole issue of geographics, but the whole issue of need, is it just based on VA's numbers that they have contracted to placing
No.
folks in facilities?
No, basically what we do is when we started the grant application, we do a research project throughout the state of New Mexico. So we look at all of the different geographics for veterans located throughout the state. And then this particular project, since it's for Alzheimer's, I gathered data additionally about Alzheimer's population in the state of New Mexico and how those numbers are supposed to increase over the next year. So that data is what we use to put forth the project. So it's in combination with what the VA looks at for bed need, and they have a list that comes out every year on different states and what the bed need is by state. Currently, I think our last list shows that New Mexico is in need of 400 additional veterans beds at this time.
And I guess because I'm just going based on my experience in the last year with, actually it's 2 years with my father and my best friend's father, and both vets, and they were placed in external other facilities.
Contract homes?
Yeah. And so are we looking at trying to just create all veterans facilities type thing and then discontinue contracting, or?
Well, the contracts are through the VA itself.
Yeah.
So what they do is they look at the local community. The veteran has the right to choose whether or not they want to travel to a veteran's home or if they want to stay in their community. And so, for instance, Albuquerque has several homes that are contracted with the VA to provide veterans bed services. So veterans that live up in Albuquerque, Santa Fe have the choice to say, yes, I want to go to this contract home, or no, I want to go to the I don't want to say the real veterans home, but the exclusive veterans home in the state of New Mexico, so they can make an application to our facility there. So,
And what we find is that you probably have a significant waiting list.
I do for my Alzheimer's population, yes.
And so,
Yes.
And I think that's the population that is going to see the greatest spike.
Correct.
Working with the TBI data from the current war, and even now that we're starting to see the effects of TBI, traumatic brain injury, that go back even to the first Gulf War, and even all the way back to Vietnam, that weren't recognized as TBIs before, but now we're starting to see those go into Alzheimer's level care as a result of those injuries.
but it's not Alzheimer's.
Right, correct, but it's
it is a type
Alzheimer's
of,
level.
It's the type of dementia.
Right,
So that's what.
And Alzheimer's.
So it would be Alzheimer's and other related dementia.
That's correct.
correct.
Dementia related.
The VA, they just finished a construction project. If you were down in Albuquerque and saw construction up on the roof of their building, that is another Alzheimer's level unit up on the 7th floor. So, but they know that was only 25 more beds. There's still going to be a huge deficit across the state.
Okay. I guess it's important that, I don't know whether you realize that we now have the Office of Alzheimer's and other related dementia within the Department of Aging and Long-Term Services. So it's important that I think we communicate on that piece.
Right.
The other piece is we have the Veteran Self-Directed program that we're rolling out. It's in partnership with the actual Veterans Medical Center. And it's basically it's designed to provide services to keep, for the veterans to be self-directed, but to keep them in the community. So it's kind of like the direction that we've moved with New Mexico in long-term care is to deinstitutionalize.
Correct.
And so it's important that I think we work with each other so that if an individual is in the community and then it's that next phase, or if they're in a facility because they don't have the supportive structure at home, and once that supportive structure system is in place, the transitions back into the community and stuff like that. So I'm just saying I think we're doing some great things and moving in the right direction. So I'm just pointing out that.
And our goal at the Veterans Home, and the same at the VA, is to provide the care for the veteran at the lowest possible level. So if they can stay in their home with minimal assistance, that's great. What we find applications to our facility are those veterans that are in need of some pretty heavy-duty medical care that they just can't provide in the home. So.
No, I just found that I'm trying to pursue this, so I applaud you in your efforts with the VA, but the medical centers are like a sovereign nation.
Yes, they are.
And they seem to, regardless of what the federal government is trying to guide them in the direction, they seem to have the ability to choose what they want to do. And so this Veteran Self-Directed Initiative, Secretary Ward was wet behind the ears at the Department of Aging when that thing started, and we're just finally getting this thing rolling. So somehow or another, it's based on a study that it will save them money if they move them out of the facility.
Right. And that's the general VA model on almost all their programs, is to try and be a shepherd for them, but move much more of the actual boots on the ground out to these states and the communities. You usually find it's better health-wise for the veteran. B, it's less expensive for the VA, and there's more cost sharing across the community. So that's the model on almost everything that they're doing right now.
But I agree. I think you need to have another facility.
Well, that's the expansion is extremely important to us, so we're not giving up on that.
Right.
So I appreciate all that. That was a good discussion. And I think I'll have Retta comment. We're kind of excited. We're trying to do some leadership training, which we're always trying to do for our senior management team, which includes our administrators. And we've got something lined up on May 15th.
May 15th from 9 to noon in the Rio Grande room of the Tony and I building. We've invited Mark Williams from the Motor Vehicle Division to come and spend some time with us. Mark Williams is a Six Sigma black belt, and he's a lean expert. He has a very deep background in leadership and change management, particularly government processes. And he has, in less than 2 years, transformed our motor vehicle division into one of the top performing motor vehicle divisions in the country without extra money and without extra staff. It was very, very impressive. And he did a presentation for our Division of Health Improvement a couple of months ago at an all DHI employee meeting that was really helpful in terms of understanding how customer service has to be a priority for government entities. Even though we're the only game in town for bringing the services that we provide, we still have to be concerned about providing the absolute best customer service that we can. And he's very good about showing why it's good for employees to do that too, that it changes their lives to be good providers of customer service. So he's going to spend a couple of hours with us, and he's asked me to solicit from the people who will be attending what their top issues and challenges and opportunities are, so that he can look at those before he prepares a tailor-made presentation for us and then interaction time with us. So you're invited to attend that day. I would love it if you could come. It's going to be, we booked the Rio Grande room, so we have room for a big crowd that day. So just let me know if you plan to attend, and also send me your top 2 or 3 issues and challenges and opportunities, and I'll consolidate those into a document for Mark Williams prior to that day.
Mine will be the LFC review hearing that I'll be going through around that time.
Well, okay. That's after.
Well, I've been dealing with it.
That's right.
Be following up on
Any other comments I want to make? I think sometime during the session, we've got both Jeff is here from on the IT side. We'll make sure we talk a bit more about ICD-10 and Avatar at some point this morning. Even though I know the federal government's, President Obama, I guess, has signed something, rolling it back another year, we're still moving forward with getting it in place.
Yes.
So we know we'll probably still be using ICD-9 on October 1. But I know you're working real hard on that, and appreciate that. And Mike Mulligan's been working very hard with the 4 MCOs, continuing to work real hard, and so is Julie Weinberg and her staff. We've had contracts in place with Blue Cross Blue Shield, Molina, and Presbyterian, and although we're working with United, as though we have a contract in place. I know you're in the final stages of trying to actually have a formal contract in place, and we're doing pretty much monthly meetings, ongoing meetings with Julie and her team at HSD to help us with that. So we'll make sure we talk a bit more about that. That's a big transition for everybody in terms of the billing side. So I appreciate you being here today too. But maybe I'll just transition. I think I always start with Troy. I don't know why we always start with Troy, but I'll start with Troy today, and he's going to tell us. Well, you can talk a little bit about a little bit more about Monday also, if you like. And
Okay.
That went really well. You did a superb job. You and your team, you really did a great job.
The team did a great job. They actually had everything set up at 7 in the morning in the snow and had everything ready to go way before in case there was a problem. We could have actually changed. We had a few things we had to make some modifications on. You guys didn't even know that there were modifications made, so that's exactly the way it's supposed to be. Everything went well. And I really appreciate both of you showing up, and it was really nice to see the governor there. The staff are still talking about that. She spent time with them. You guys spent time with the staff, and that went a long way. They appreciated that.
Could you describe to everybody again, how phase 1, phase 2 works, and what how you're moving the residents?
Okay, phase 1 we actually completed in 2012. Moved residents in there, 36 residents that we have in phase 1. And the other side of phase 1 is more the administrative offices, a lot of the electrical, cooling towers and everything that need to take care of all 3 phases. Phase 2 that we opened or cut the ribbon on Monday is going to have 72 residents to stay in there. And actually, 4 of those rooms are isolation rooms, so we'll probably end up keeping 4 of those vacant in case we need to put a resident in there to prevent them from spreading any kind of infectious contaminants or whatever. Phase 3 is going to have another 72 beds, so we'll have a total of 178 beds that we can use. We had to give up 2 rooms. It was going to be 180 because in phase 3 we're actually going to have true isolation rooms with the negative air pressure, reverse airflow, whatever all those terms are for that, to where if we really had someone that needed to be isolated from everyone, we have a room to go into to close off before you get your cleaning and gowned up, then you go into a room. So I had to give up 2 resident rooms to get to that, but for the need in the state, sometimes it'd be good to have those available, and that's going to be built into phase 3. We're initially planning to move in. Phase 2 was May 12th. It's been pushed back a little bit. I'm waiting on the fire marshal final approval and our certificate of occupancy so I can send that to DHI. I've been in contact with them. They need to do a site visit to come out and give us the green light. So as soon as that's all wrapped up, I'm hoping no later than the end of May, we'll move in. Demolition of our old meadows was planned for the end of May. They wanted to literally have the last resident walking out of the building and backhoes and bulldozers going in and tearing it down.
Maybe double check first, though.
Well, he's going to give me a 2-week window in between the last resident going out and us demolishing the building. So
One final walkthrough.
yeah. And as tight as the budget is, Leonard would appreciate this. I want to go through and scavenge everything out of that building that we can. Part of the demolition, though, they want to leave stuff in there so they can salvage that. So there's a little debate going on with property or GSD and us, because I wanted to go all the way down to the water efficient toilets. I was like, pull them all out of there. So anyway, we're having that debate now. But we have money for the demolition, which is good.
Right.
Okay.
Okay, thank you.
The statistics there, which I give every quarter, you guys can see we had 188 admissions to our adult psych division, 198 discharges, and our average census for that quarter was 72. Our adolescent unit, we had 2 admissions to 4 discharges. Average daily census is 11. And in forensics, it was 34 admissions, 33 discharges, and our 1.5 population is still at 35. Our outpatient program, its current census is about 1,300. Our long-term care division, we're up over 150 today. We had 13 admissions, 11 discharges. We're trying to keep that census at around 150, so when the transition occurs, we can make that move more easily, and then look at putting the beds back in. We're going to actually have, in our Ponderosa unit, currently it's an upstairs and a downstairs, we're only going to have 1 floor occupied, waiting on phase 3, and then move the residents into phase 3. And Ponderosa building is one that we are looking at what services might we be able to provide in the future with that. And I know treating veterans and some type of nursing facility for veterans has come up, so we'll keep our eyes open on that. The cameras, we've been waiting on that. I think that's been in my report for 12 years. I'm not sure how long it has, but we actually have cameras in our Tasuki units. They're operational. The staff had a little adjustment to that, but when we explained how we're going to use it for training after a CPI event, I want to take that and I want to go back and look at before the event occurred and during the event to see what we can learn from that to be more efficient and more effective, and maybe not have to use any type of CPI interventions or seclusions. And we're also looking at them being in all of our patient care areas. We're waiting on a few POs to finish that project up, so that I'm really expecting that to be done definitely by the end of May.
Troy, I have a question. Who's going to be trained to actually view those videos?
It's already, we're doing it the same as we do in forensics. These will not be live watch, live feed. These are closed systems, and so the only people that have access to it is security. If our internal review department wants to access that information, they fill out a request saying what it's for. It goes to security and to myself or my designee. We approve it. They can go in and pull that.
So we have the internal expertise to actually go back and view the videos.
Absolutely.
Excellent. Thank you.
Absolutely. And from a personal standpoint, we had 84 positions that we filled for this quarter. Some internal movement, if you can see, because over half of those were internal employees. Advancing, 40 of them were new employees. Dr. Collins has done a great job of recruiting psychiatrists. We have Dr. Dunn as our chief of psychiatry. We're stealing him from UNM. Not stealing, we're recruiting. Okay, yeah, we stole him from UNM. And he's going to start May 12th. There's also another psychiatrist that's going to be starting at that same time that is a colleague with Dr. Dunn. So Dr. Dunn has his own following. So if you need any psychiatrists, let me know. I might be able to sell those to you.
We do.
On the primary care side, Dr. Demet, who's a neurologist in our community, I think she had 30-some-odd thousand patients that she was following. There's very few neurologists in New Mexico. With the change of managed care, we were able to recruit her and bring her into our facility as a full-time FTE. So worked out real well. We lost Dr. Ayad. He actually resigned, went to live in Santa Fe and work in Santa Fe, was where he's from. We call her Dr. Desi, I can't say her last name.
Tsitsoris.
There you go. Was voted in as our president of the medical staff just until the term in June 30th. We'll have a re-election. You guys already know about the restraint-free certification that we received in January. One of 5 nursing homes in the state to be certified. It's the first time I'm ahead of Lori and Jeremy in anything, so I wanted to put that in the minutes.
It won't happen again.
Exactly, I know it won't happen again. That's why I'm taking my moment now.
Savoring it.
And we have actually a monthly meeting scheduled with the MCOs and weekly meetings scheduled with OFM and the facilities to go over working on our managed care contracts to make sure that we're capturing all our money that we can and seeing some difficulties in our adult psych division, collection of revenues. For that IMD exclusion, I think that's still being worked out.
Right.
So we're hoping to see some revenue coming in through that, but as it looks right now, it's not what we had before.
Right. And I think, Whitney Ann, are you guys going to do a tour in September or October?
August.
I think, right?
That's correct. The legislative, is it August? Yeah, it's August, that's right. The Legislative Finance Committee will be meeting in Las Vegas August 15th through the 17th or something like that. So we had contacted you all, and Troy had graciously agreed in you all to do an early morning tour on one of the days. I can't remember all the days right now, but we appreciate it. Get all the legislators over there.
3 o'clock in the morning is when we'll start.
In the Florence unit, right?
We would like to, we're going to work out the details, but in the past when they've come over, we've gone through pretty much the entire complex that we can, and depending on the amount of time they have. Our big focus usually is we show them what their money's gone to before and how we've utilized that money, and then areas that we might need monies for in the future. So we use it to our benefit too, and give them a tour of the facility.
It was too bad that you weren't able to get the capital outlay monies in. But I know that Linda and her folks and all keep working on it. And we've actually started, it's okay, just take it.
Sure, go right ahead.
We've actually started a process where we're going to be reporting on capital outlay, doing a sort of a little one-page form for the committee whenever we go before them during the interim and during the fall. So they have a little more update on where we are with all the capital projects. That's for all of the agencies, so for aging also, and I'm not sure for veterans and all, because I think it's $1 million and over, so it'd probably be more for aging and DOH. But I think that'll be a good thing, so they'll be more aware of the projects instead of just seeing them sort of when they hit, primarily at the end of the calendar year. So,
Okay, great. Would anybody else have any questions for Troy? Okay, great. Thank you. Sure, go ahead.
Sorry. It was on the reimbursement, and it probably is gonna one for all of them.
Sure.
I know I always get them wrong. It's the other codes provider. There was United, and then there was Evercare.
Not Everclear, it's Evercare. They're very good. Just making sure you.
My fishing buddy over here. But have you guys finally cleaned up reimbursement from these folks?
It's an ongoing process. United, today, we don't have a signed contract, correct, Mike?
Correct.
And so we've actually seen some payments coming in from United, but I think given the delays in getting the contracts cleaned up and even some pieces we were billing under the codes they had in their contract, and then they were denying them, saying it was wrong codes, and so it was a lot of bumps in the road, if you will. I think we're coming out of that. We still have a ways to go, but I think from our facility is actually doing everything we can to make sure, and I'm sure everyone else is, to make sure we capture every nickel that's out there.
Sure. Mike, you want to comment on that? Or?
Sure. I mean, I've got numbers here that we could discuss either briefly now or in more detail later, but we've got about $3.6 million of AR outstanding that has not been paid. But the MCOs as a whole, and you expect this generally sometimes with any new program, we went from 2 long-term care MCOs to 4. So it's a new business for long-term care Medicaid reimbursements from 2 of our MCOs. But we've got about half of our claims been paid from January through basically the end of March or early April, which is not bad given it, but we are having to follow up on a lot of things, getting the codes established, the contracts executed, the billings to flow with new providers. It's been quite a challenge, but we've been working hard, and we feel like we're kind of almost where we need to be. We're a little bit behind the power curve, but we have also established monthly meetings with the Medicaid director to discuss this. We've shared detailed concerns with them from every facility and the public health division. So we're working hard to make sure that this stuff is, if it's not moving, at least it's identified and we're working on it. So it's a mixed bag, but we feel like we're not too far behind the power curve. I mean, we're about where we would expect to be with the stand-up of a new program January 1st and providers who have never really been in the Medicaid business on either the long-term care side or the behavioral. We went from 1 behavioral health MCO, Optum, to 4. So there's been some growing pains, but we feel like we're, on top of it as much as we possibly can be. So.
Mm-hmm. Yeah, I think we have another meeting with Julie next
Monday.
week. Monday,
Actually, yeah.
On Monday, okay.
I have a quick question.
Sure.
Mike, how much work do we do at all with Magellan?
Magellan is the behavioral subcontractor for Presbyterian. But we've kind of insisted that we're dealing with the 4 contracted MCOs and not their subs necessarily, because we just can't fragment this process anymore. And so they wanted us to credential separately, and we said, no, we're working through Press. They wanted us to, so their Press is behavioral provider, so we do a fair amount of work with them, but we're going through Press on the Magellan side.
Okay.
I just had a quick comment, Troy, about, I also get the opportunity to meet monthly with all 4 MCOs around basically care coordination for CYFD children. But one of the things that's come up that I wanted to be sure and talk with you about, and my idea would be you could inform the MCOs about a better, I think it was Melina, we were talking about a 17-year-old young lady with an IQ of 63, and they were like, we found this great website. It's called New Mexico Behavioral Health Institute, and you can go there. And I'm like, not thinking that this is at all what, and they're like, they have group homes and all this. And I'm like, yeah, but it's not really for 17-year-old girls with an IQ of 63 who would more likely be a victim than a resident there. I'm like, if they could get a better sense, because I got a good sense of it when we toured up there and you gave such a good explanation of everything. I don't think they even have a clue about that, and it's come up a couple of times now. It's really complex, hard to handle. Not really sure, they're on the waiting list for the waiver, but, that's 10 years long and this and that. But I just wanted to bring that to your attention. If you might want to do some more education about who is appropriate to go to NIMBY, and they're very confused about the board and care homes. They kept telling me, well, there's these great group homes up there. And I'm like, you guys, I'm pretty sure those are board and care homes. It's not exactly a group home. Yeah, it's not exactly what you guys are envisioning.
They're care coordinators.
It scares me that the MCOs are starting to look at the state hospital. I'm like, no.
That scares me too. When we met with the care coordinators from all of the different MCOs, because we've had individualized trainings, we did it in our outpatient division in the chapel where we could get a lot of individuals in there. What we found was a lot of variation amongst the care coordinators. Some of them, if I have somebody down south and you're a care coordinator for this person down south, when they get admitted to my facility, they actually come, they're the ones responsible for tracking them and following them instead of doing a handoff to the people in our community that would be more familiar. One or two of the MCOs are doing that. One, I think, is changing to that because we said it would be so much easier to do a handoff and not relying on someone from way off to come and do that. And then even having meetings amongst their care coordinator directors or supervisors so they could discuss what services and pass that on. We caught the ones that were in our catchment area, but not the ones down in other parts of the state. So we're trying to work on that with some of them on the trainings. Yeah, it is scary. Our own acute care hospital doesn't understand. Anytime an administration changes or a doc changes, they don't understand the complexities of our facility and how our individuals become their individuals sometimes, and other times they don't, and it's complicated.
It is complicated.
One of these days I'll figure it out.
That's true. That's good input for Mike too. I know when you're having, we realize that, as you said, it's a brand new territory for some of these MCOs. So
They're kind of confused fundamentally, and there's a lot of variation among the care coordinators in their understanding of it's their responsibility to track someone. Because a lot of times they'll say to us, well, it's CYFD's responsibility to track that person.
Right.
We just kind of pay the bills. You know, so there's a couple that are in that mode and a couple that are more trying to figure out what to do. But pretty stunned is what I'm sorry, I forgot you were here. Kind of stunned is more of their expression, and just a lot of talk about we got to get our health risk assessments and some of those things completed that because they're facing a big sanction.
No, it's just a fact. I mean, it's just, it's just stating the facts as we see them right now.
I just take same from her.
Sure.
So, interestingly, was it last week or 2 weeks ago, just on the care coordination issue, technically rural care coordination, New Mexico was one of 3 states. Nancy Smith Leslie presented on behalf of MAD, along with Montana and Colorado, on their current Medicaid rural care coordination processes, and did a national presentation. It was actually a webinar, and talked about the model here. Obviously, was an MCO model and how it's sort of farmed out, but they were talking about it and the things that are written into the contract to assure that rural care coordination does occur with the 4 MCOs. So we were lauded as a model nationally. So if that's not getting rolled out in that way, and interestingly, Montana and Colorado have very different processes for rural care coordination in their Medicaid programs. Very different. And I don't want to take much time, but just the Colorado model is very much grassroots and more from the sort of local areas up. It's not a centralized model. The Montana model is more of a hybrid. But interesting for you all to know that. So you might want to leverage that perhaps a little bit in your work around that. And my question actually was, Daphne, for CYFD, I don't know if you know this, but are your claims at about the same rate, more or less, with the MCOs, your unpaid accounts receivables at about 50%? Are you having the same issues? Or
I am happy to tell you that the entitlement unit switched over to my colleagues in juvenile justice, so I don't oversee that directly anymore. I'm very, very pleased to tell you that. So you would probably need to check with Nick Costalis because it's under Nick, and I really don't know anymore that sort of issue. I get more involved in the clinical issues around placement and lack of being able to find placement and those kinds of issues than I do the payment part now.
Do you know, Mike, if Medicaid's at about the same? I don't know. I was just curious if they're being slower with DOH than what they are with maybe some of the others, and find a way to prod them.
Well, I mean, we expect it to go up. A lot of it had to do with coding and setting up the contracts by the MCOs in their systems, and sometimes people not knowing that a contract had been executed because it hadn't been loaded yet, or I mean, there's been a lot of,
Very labor intensive.
It is.
All the claims were filed in a timely manner, so we have the ability to go back and get those revenues.
We have been working it. Well, we've been working it every week. We constantly talk about it, and we're constantly meeting with Julie's team about it. So we're doing everything we can.
and we have weekly meetings set up with each of the facilities and public health to identify issues, report on successes and roadblocks and speed bumps, and work through them, and also just raise the issues up and so that we can take them to HSC as need be or the individual MCOs. That's all.
We have present our building at 1 o'clock today, which I'm going to miss to be with you lovely people. It's much more enjoyable to be here.
Well, I'm glad they're in the building. That's good. Okay, let me go on to the next report. Charles, want to give us a report on Sequoia?
Yes. Good morning, everyone. I'd just like to start by saying that Secretary Ward, it was really nice to hear about the upcoming leadership meeting that we're going to have in May in terms of the change management, because if all of you probably know that Sequoia continues to work through a transition from what's considered control to collaboration, and part of that change management is about changing the culture of how the staff think, how they do things, and how they interact with the clients, residents, or staff that we have. And let me tell you, it continues to be an ongoing challenge. It was really nice to hear that we will be getting together to talk about what that really looks like, and to possibly get an outline that we can actually follow as an organization. So it was great to hear that. That being said, in terms, I'll just start off with our census for this quarter. In January was 19, February was 16, March it was 12. Currently our census at Sequoia is 12, and I acknowledge that I think we're all going through increasing our census across the board in DOH. I do have a goal of attempting to reach at least 20 by May 1st, but that being said, you know, the thing that we also have to consider, I have to consider with my clinical team, is the mix, to make sure that we're bringing the appropriate young men into our facilities, and not to increase the current, I think they're referred to it as the, not the census, but acuity, you know, with that mix. 20 doesn't sound like a whole lot, but when you're in a transition, 20 feels like 100. You know, so we just need to be mindful, we're being mindful about what that looks like. We continue and successfully move forward with hiring new staff members. We've actually hired a total of 11 this quarter. 3 were mental health supervisors, but the people that actually really get down and do the work were our mental health technicians, and we've hired 5 of those. We continue to recruit our mental health clinicians for our techs. We've hired 1 nurse, and I think we all know how hard those individuals are to find. So we're really grateful to have been able to find one of those. We've also hired 1 therapist as well as a safety officer, and they've accepted. We're just waiting for their clearance. So as soon as that comes through, we will be hiring them, and they'll be on the floor ready to go. We've also hired an educational assistant who sometimes actually covers as a psych tech on one of our, not psych tech, because we've changed that designation to mental health technicians. They also kind of double as mental health technicians on the floors. Moving on, in terms of our projects, we're in phase 2 at Sequoia with our HVAC project, and also we're moving forward with our key access. We did do something very similar to what Troy was talking about with our cameras. They're all set up throughout our facility. They actually have proven to be a very good asset to actually be able to review any concerns we may have about restraints, what it looks like, what we can learn from it moving forward, what we can use to make sure that we don't have to restrain a young man, what we can do differently. That's been very helpful in that aspect. The other part that we are continue to work on is our courtyard project, which actually has to do with removing all of the rocks that the kids have access to. Because in our courtyard, it's built on a bedrock. Doesn't matter how many you pick up, there will be another one there 2 minutes later if you drag your feet. So it's an ongoing issue, and we do daily safety sweeps to pick up as many as we possibly can to make sure that they're not accessible to our kids. The other part is we're working on as a project is replacing all of our current windows. We have a lot that's on the interior of the facility with carbonite, I think is how you pronounce it, or plexiglass. The funny thing is, a couple of days ago, we had a kid that was out there, he picked up a rock, and he threw it at the window, and it bounced back. And the staff they tried to compose themselves, but the kid picked it up again, and he threw it, and it bounced back. So the third time he tried, a staff member stepped in front of him and he got mad, but we took care of that and he de-escalated. But it was really great to hear that the plexiglass is working. And the kid didn't really like that because he didn't finish the task at hand. But those are the things that we do that, to every day I share with my people from point A to point B. You have to be vigilant, to do safety sweeps. If you see something, if you can't remove it, let another staff member know as soon as possible if you're the person escorting that student to make sure that the next student that comes through doesn't get access to that. Okay? Under the miscellaneous pieces, actually yesterday we had a grand opening for what we're calling our Sequoia Eagles store. And simply what it is, it's part of the phasing out of the old and bringing in the new. It's simply a way of rewarding, if you would, I don't like that word, but our students for just following program. Part of that is that we've created what's called Sequoia Bucks, which is a form of BMS, behavior management, but it's not punitive in any way, shape, or form. What we ask them to do is basically follow program. And if you follow program, you get a B or an A in school, you're rewarded for that. If you compliment your fellow students, you could get rewarded for that. If you clean something as simple as clean your room, because we know our kids hate to do that, clean your room without being told, you can be rewarded for that. And when they collect all of these Sequoia Bucks, there are certain times during the week that they would be able to go to the store and purchase one item. You can't, if you have 30 Sequoia Bucks, we're going to let you spend on 30 of them. It's kind of like a combo deal when you go to McDonald's or somewhere. You can just purchase one thing. And we told them about that yesterday during our grand opening. We had the cultural committee brought in some Irish dancers. There was a group of 4 young ladies. We took them all to the gym. All of the students actually were there together. They interacted very well. They played some music. The ladies danced. They even had some of our students interact with them. They were all appropriate, and there was a couple that just jumped up when they said we wanted volunteers. It was very positive. And so after that's when we set them down, we kind of explained to them in terms of expectations, what the Sequoia store is about, how they can gain access to it, and they were really thrilled about it. They wanted to be able to earn money right away, so they could go and access the store. So they were really excited about it. I was just, in awe that they were all together. There were no issues. They asked the appropriate questions about it, and they're really looking forward to it. And then the other item I have on here is that we did get our lodge certifications. It's like part 1 and part 2 of LCA the license and certification agents that comes through. They do our facility and then they do the clinical piece. Right. And we successfully were able to get our certification for the certifications of each one of our 4 lodges. So we're just waiting on the other piece, the paperwork to come in to see where we are with that.
Good.
Pretty awesome.
Gail, do you want to make any more comments too about building bridges?
Sure. Tippy Watson went to a grant writing program a few months ago. And there's a lot of opportunity out there with SAMHSA. There's some monies available through SAMHSA. So we're starting down that road for training for therapists, training for mental health techs, training for nurses, based upon what the needs are for our population. We were successful gaining some education and training for this summer, probably to the tune of maybe $15,000 to $20,000 in education. We want to include all of our facilities in this. We've got Tippy housed out of Sequoia right now, but we really think that there's some opportunity out there, and I think just with the Affordable Care Act and the amount of focus on behavioral health, we can really start to access some of that talent out there. Secondly, we have, thanks to Brad and the team at the Reynolds Building, We have, again, gained access to Belleville and the Building Bridges framework again this year. Our next phase of that, we've got some of our private sector folks that have really embraced this. I'm really proud of them. They have changed their points and levels programs and to a much more collaborative positive supports model, and they're definitely ahead of some of us that have initiated. So we're going to do this again this year. We want to really incorporate this from a statewide perspective, and I mentioned this to Ruby Ann last year a little bit, but I think we've accessed some of the other states that have embraced BBI and the amount of cost that it's reducing in recidivism and readmission, the amount of attention it's getting for really great outcomes for our kids, staying in school, staying out of corrections, and basically staying out of gangs and staying alive, basically. Also, trauma-informed care is a new, well, it's not new. It's not new to the behavioral health community. It's actually kind of new to me. But we've got extensive training coming forward in the SAMHSA grant for trauma-informed care. And what that does, for those of you that don't know, that teaches our employees, our caregivers, how to care better for our patients or our kids, our students, whatever. And so so I think going forward, I would love to see this even get attention from our state lawmakers and really embrace the state of New Mexico in a front line. Here's how we take care of our kids. And I think our providers or our United Health and some of those would love to hear this, because it really does focus on one programmatic model. It comes with one set of outcomes, and it's like long-term care. You kind of measure each other against the same outcomes and how we're doing. So I can envision this thing coming into a core model of care for adolescent treatment.
You know, we really need to intersect it with our New Mexico Cares wraparound model, and some of where CYFD is taking the core service agencies, because there's a lot of complementary pieces to Building Bridges. I haven't been able to get to the meetings, but Michael Hawk, I think, is representing us. But really, as we look at also our communities of care framework, where we want to empower the local community to design a system of care for their youth that have significant behavioral health needs. I think it dovetails really nicely with Building Bridges, but finding a way to combine those things together, I think, would be really awesome.
Well, maybe somehow we could connect together and kind of envision how we could do that, because I think our MCOs would love to have one website that they access to say, here's who does what, and here's the framework we use, and here are the outcomes we're monitoring, and here's the return on investment that you're seeing from this. And this is the best practice as we collaborate with other best practices in other states to say, here's how we compare and contrast. So it's really got some great opportunity. I think it's growing some legs right now. Desert Hills, the chief executive officer over there has taken this by storm. She's doing a great job, and I'm just tickled to see what they're doing over there. So it's tremendous for the state. I can just kind of see this vision coming to fruition. So I really appreciate the help with the monies coming through.
For those of you who haven't heard these terms before, trauma-informed care is based on the principle that when these kids and children come to us, they have been traumatized, and we do not need to further traumatize them in trying to provide the care. SAMHSA has published a free book on trauma-informed care that we've already got like 15 copies of, because we've have various people order them. They're free, there's free shipping, so if you're interested at all in finding out what this is all about, get in touch with us and we'll give you the address.
Yes, sir.
Just to add, it's, not just for kids. Trauma-informed care is also very important for our adults. That almost all the state psychiatric hospitals use trauma-informed care. We went through our advanced CPI, is what they call it, to include trauma-informed care and more de-escalation techniques. And I've heard there's some experts over at Turquoise that have some trauma-informed background and experience, and we were going to ask to have them come out and assist us in doing our CPI trainings, because I think our trainers went and got certified in it, but they're still uncomfortable with the concept of how that plays, because it's so foreign to what we've worked with before.
And the VA is the expert.
Yeah, absolutely.
They are the experts, you know, we're
We-
sitting here with the expert in the room.
Even with our
Yeah.
state service officers, we,
Yeah.
at our annual training now, we include a block on that type of deal.
And we might even tap, I don't know if you, well, how much, what you have for resources there, but they are the expert for this kind of thing. We're just kind of still scratching the surface.
Okay, great. And we do want to, we're definitely want a very strong collaboration with CYFD. So we should be partners.
Well, and you know, we
work
even
closely together.
thought about, I don't know if this is a thought for you, Daphne, but embedding some of the building bridges framework criteria into the licensing, the licensing administrative code. So you know, when you go, or somewhat what CMS does as well, when you go to license an organization, that they are in compliance with positive behavior supports, quality metrics, a restraint-free environment, those kinds of, so you know that framework is being implemented in all of the facilities that are under the state licensing. So that would be a terrific way to really embed this thing, so everyone embraces it.
The biggest problem we have, I think, with our behavioral health system in non-facility-based services is the reimbursements don't follow the philosophy and the words. So even if you have MCOs talking the talk, but they don't pay for it. So we're really struggling with that with our core service agencies that are kind of all on life support,
Right.
with the exception of Troy's, because he has the state behind him. He doesn't have to make his money in the way that some of them do. But it's very, very frightening to me that because we have a very thin veneer.
Yeah.
Right. We have a really thin veneer of services, and they're just not. It's really frustrating because as a New Mexico taxpayer, we give those MCOs that 1/12 draw at the beginning of every month. So we already know they have our tax money, but we can't get them to pay the providers for services to take care of our children at a level that meets their needs. And trauma is, Dr. Davis says trauma is the house, our juvenile facilities are the house that trauma built. And as we start to look even at shelter care and we're measuring adverse childhood events, there's kids, average scores are 5.5, 6, and we have another small population of kids that even have higher numbers of adverse childhood events. And so their health trajectory is really impacted. And I know it seems weird to have me talk about somebody's chronic disease when they're 50, but that's what's going to kill them, and it's the trauma that's at the base of this.
Yeah.
And the MCOs kind of get it theoretically, but they're not willing to put the money in the community where we need the money to be so that people can do their good work.
Well, I asked
It's
about
really
Magellan,
hard.
because Magellan's really embraces the trauma-informed care.
They're not doing any better.
They're not doing any better. Well, and then there's the literature that's out there that talks about the outcomes, embracing, is that it actually costs you less
Right.
to take care of a child with a focused program. So you actually can save money.
I totally understand.
Yeah.
And since 2008, we've been pushing core service agencies and comprehensive community support services as kind of that bedrock of the system, and nobody will pay for it. It's really frustrating. So for me, I just want to make sure that the money is following the words into the community, because it's really difficult, and we may have an RTC placement denied, or they want us, to make it really short, but we still don't have enough bandwidth in the community to really keep someone safe, and so we're still kind of challenged by that. So I'm really not very satisfied, to be honest, with where any of the MCOs are with their rhetoric. I think Melina's probably closer than anyone at saying, what's this wraparound thing you guys are doing? Have we figured that out too?
Yeah.
And that kind of thing. So there's a little bit of a conversation, but I just really want to caution us not to be caught in their words, but to really look at what they're doing,
Right.
their actions, and not their words, because words are falling kind of deaf for me right now.
Yeah.
And I'll tell you, I'm a little obviously frustrated,
Yeah.
because we have children's lives at risk every single day. And we're just doing the best we can and hoping for the best, kind of like Mike's attitude of, take a long-term approach, but we can't let them get by with the nice words, which honest and truly, we got a lot of that from Optum too. We got a lot of words, but then when push comes to shove, medical necessity is super important. But for CYFD, when we're looking at child well-being and the rehab needs of our juvenile offenders, and we want to produce productive adults, sometimes not moving that child or changing that level of care at this particular moment is very important developmentally for where that person is, and that never gets taken into account. So I think we just gotta wait and see and keep trying to keep them honest.
Right.
Yeah.
I would agree with that too. And I think Molina, of the four, we found them to be at least so far, the most receptive to listening to us and our concerns.
Correct, yeah, they were the only ones, we signed with them on December 31st, actually, and they were the first MCO we signed a Centennial Care Agreement with for Medicaid. So they've been very responsive and cooperative for the most part.
And they have a lot, between Prez and Molina, they have most of the CYFD children. United hardly has any at all. And Blue Cross Blue Shield somewhere in the middle. And they seem okay.
I agree with that. I mean, it's an ongoing, it's very labor intensive. You can't just hope that this works. You got to work it every day and every week. And that's what we're doing.
And the money needs to come to the hands of the providers.
Right.
If it stays in the hands of the MCO, then what happens with it?
Right.
And I think it's interesting as you're discussing some of the who's cooperative or who's working with you on this, and then you see in other areas some of the other MCOs really concentrating in those areas, and some of these others are not necessarily concentrating and doing so good. So, so it's interesting how you're pointing out Molina, and I'm like thinking of some of the issues we're running in with them.
Are they talking about paying on an outcomes model at all?
Oh, performance-based contracting is the word that they use. It's discussed, but it isn't. There's not a lot of action right now. Optum did a couple of pilots with kids. They did see great reductions in cost. But there again, it's difficult to get that to the next level, to get that as a mainstream way that people are reimbursed. It's really very, very difficult. We're still trying to do fee-for-service really well, which is kind of like too late. I think we should focus on performance-based, but it's really difficult. We're looking at how we can use our state general fund dollars to start to pay providers based on performance or incentivize their performance.
That's where the Building Bridges framework comes in. As we start developing these outcomes of care. And the outcomes of care are like core measures. What CMS and Joint Commission do, they have core measures, and then you build more core measures based upon the initial data, and then they pay you on the outcomes of the core measures.
I'm really familiar with how it works.
Exactly.
It's difficult
so that's
to
where
make.
the BBI, trauma-informed care, comes in. We establish those out, and then we get paid. The better you are, the more you get paid.
So as you said, the weak link is MCOs.
Right. They
But
love to talk about it,
Right.
but when we get down to let's do a demonstration project, and we're really trying to get dollars out to our core service agencies because we see that as the basic safety net. And I think the MCOs are starting to see them as a safety net as well. But it's really difficult because they can't, it's hard with, if you have to upfront the care, pay your staff for 6 months and then hope that you get paid. You have to have a lot of money to really compete in those kind of environments. And, our providers they just don't have a lot of money that they can put out 6 months of payroll and hope that they're going to get money back on a promise.
Well, it also sounds as if these are things that need to be delineated in the contracts. The expectation for the payment, the outcomes. We need to be very specific about that in the contract, because if it affects their payment, the MCO, the money they receive, they will respond.
Absolutely.
Yeah.
Well, good feedback.
Yeah.
Thanks. Sure, go ahead, Vivian.
May I ask a question regarding Sequoia and sort of the issue that Doug
Sure.
was saying? So, to piggyback on the RTCs, the MCOs deny RTC placement, have they denied any RTC current or recent RTC placement for Sequoia, 1, and 2, do you have a waiting list, and what is the waiting list?
No, they, to date, we have not had any of the MCOs deny any of our admissions. In terms of We don't have a waiting list per se, because a waiting list would indicate that we received the information, we reviewed the information, and we're waiting on the bed. So we don't have a waiting list in that sense. What happens is when the referrals come in, we review them, and then the committee, the admissions committee, gets together and decides which of those individuals are appropriate in terms of the mix. And so then what we do is then we will shoot that information to the administrative level to then decide whether or not those individuals are appropriate.
Maybe I should reframe my question. What's the need for male adolescents to get into an RTC in the state right now that are waiting for placement into an RTC?
Okay.
That's a little different in terms of our criteria may be different from someone else's. Our criteria would be the age. They have to be at least 13. They also have to have, that's not really relevant, a history of violence, that they have a mental health diagnosis to be considered.
So do we know what we're looking at in the state? Do we know what our need is?
I think it's quite high, but I don't have that.
No, I
Good information. There's a lot of need, obviously. So we have a great desire, I have a great desire to increase our census there.
Right.
It certainly functions as a pretty high level of care. It's almost at, to me, an acute level of care criteria. So I kind of see Sequoia as a specialized program that does have a higher level of acuity and can handle more complex youth. And I would say, Rubian, we do have girls too, though, more young people that have kind of intermittent explosive behavior. I don't want to say that they have that disorder, but they have those eruptions of behavior, and it's really difficult to find providers that will handle that without it turning into some kind of a charge. You know, you get charged against a healthcare worker. So it's really difficult for, we have some youth that have extremely high and complex needs, and it's difficult to find environments for them. But I don't have I don't know that anyone has, there's 20,000 or something that don't have a bed. I don't know that.
Okay. Let me move on to Turquoise Lodge. Shauna will have to give a report to us.
Okay. I guess I need to speak differently about my report because I haven't been there very long.
Sure.
But the process that I've been going through is pretty much just getting oriented. I don't know how much you guys know about Turquoise Lodge, but we lease a building from the county on Zuni. And at the bottom of our hospital, we have a program which is run by the county called MATS. And so it's a program that functions 24 hours a day, 7 days a week. The goal is that adults are able to be transported to that program, reside in the MATS program approximately 3 to 5 days. And what our relationship with MATS is we run a social detox urgent care on the same floor that's open from 8 to 8, 7 days a week. So the hope is that folks are brought into MATS. They're seen by our medical staff for an assessment. And we, at this point, are probably seeing approximately 12 to 15 people a day. It's staffed with a medical provider, a nurse tech, and a nurse. And the goal is that we are assisting that person in the social detox process. I'm in the process now of meeting with the county on a regular basis. I meet with Katrina every other week. So I think we're doing a better job of just troubleshooting things that happen because we are transporting folks who are quite impaired to our facility, and both of our staff are kind of dealing with them in different kinds of ways. So I've set up a meeting where we're trying to troubleshoot things on a more proactive basis in addition to improving our customer service, making sure that we're open during the hours that we say we are, providing the services that we are providing, in addition to hopefully having these folks come back for any kind of additional medical care in 3 to 5 days that they're there. So that's MOTU that interfaces with MAT. I've also been in the process of really trying to compartmentalize the programs that we have at Turquoise Lodge. We have an adult detox program and we have a child detox program. So we have 10 beds for adults and we have 4 beds for kids. We also have a rehabilitation program, which is a social model. And so really trying to assist my staff in understanding how care should be provided somewhat differently on the rehab unit versus a detox unit. We started our adolescent program approximately a year ago, but I'm sure you guys know how difficult it is to start a child program in an adult facility that's been existing for the last 50 years. So I'm in the process of really changing the access system for adolescents. Originally it was set up kind of the same for adults and kids, and as we know, we need to be more mobile with kids. We need to go to them versus them coming to us. So I now have an assessor who's going out to the shelters and to YDDC, to the homes, and actually conducting the assessment in the home, and us having an admission staffing every day to have that turnaround be quicker. So we've had a lower census in our adolescent program, but it's slowly creeping up. And, you know, assisting the staff in learning that kids run, you know, and kids want to run and they can call their parent and say, you know, I know you just dropped me off, but I want you to pick me up. And they do. And so that whole culture with training our staff at the hospital is something that I've been really putting a lot of effort into. Our average census for our detox adult program is between 4 and 6. Our average for adolescents has been really low, so it's been between 0 and 1. So I'm now having the shelters teaming with Steve Johnson and folks from Omnistad coming to our facility and doing walkthroughs so that they're aware that we can service kids in those types of conditions. Wanting to establish a collaborative with UNM so that we can start to share the responsibility of the detox process. So that is kind of a program in motion and creation. The adult rehab program, on average, we have about 34 adults. We have the capacity for 40, but 34 seems to be a safe census for us at this juncture. And with our kids, our average census has been, it's been as low as 2, and we are now today at 10, with at least 5 to 10 pending assessments to be reviewed. So I feel like that whole system has been really improved because we are actively going after the referrals and have a good mechanism in place to address them when we are reviewing them. I spend a lot of time learning about my job, learning about the hospital, learning about the processes and identifying areas of improvement, becoming aware of the staffing issues that I have, and really working closely with Gail, which I've been really thankful for, around just getting clear about the medical model pieces of the hospital versus the social model, and how do we use our existing resources in ways that make sense. So that's it.
That's very good. You've only been there, you said 7 weeks, and you've just been doing an incredible amount of work. And I know the staff have been really receptive to your leadership there too. So we're just real excited to have you.
Absolutely.
I know we took you from another department in the state.
We're still all to work together.
You just never know who in this room.
Works both ways.
It's Ellen Scout sitting over here.
Because it works both ways, doesn't it?
Just kidding.
Okay.
We're happy to have Shauna where she's at, and we'll be working with her. And have you talked with Jeannie Masterson and Juvenile Justice? So I know they were initially big refers, but I don't know in the change of people if they're still I would want to make, if I were you, I would want to make sure that Jeannie has your cell phone and you have hers.
I touched base with Rice Pittenger, and so we've been beginning that collaboration. When I started, there was some need to revamp the access system, so when we do say we're ready for referrals, that we can accommodate that.
Sure.
So I think we're in a place to do that.
Well, that's awesome. And if you want to have a meeting with CYFD in Albuquerque or around the hospital or whatever,
Okay,
just let me
that'd
know.
be great.
I'd love to participate.
Okay, thanks, Daphne.
Sure.
Okay, thank you.
Right.
Yes, go ahead.
It's it may not be something you want to get to at this point since you're so new, but I was kind of looking at the census information, and one of the things that I was kind of noticing is I get the Albuquerque, 47%. It's probably close to the percentage of the population, but when I start looking at the other counties, you see you think Doña Ana and Santa Fe counties will probably generate more. Is there any particular reason other than maybe geographics, or is it just
Transportation.
transportation?
So I think one of the things that we're finding with our access system, and that's something I'm trying to redefine, is that when somebody calls, that we're able to establish the whole process all in one shot. Because the majority of people who are calling our facility, they're at someone's house using their phone. The phone that they have is no longer good the next day. And so really trying to not have multiple callbacks to move forward. The second thing is that because they're not a admission, that we're running in with the MCOs, is that SafeRide is one way to get people to an appointment, but they're not admitted yet. So SafeRide is refusing to pay for them to be transported to the admission because at that juncture they're not a client. And that happens too, where folks come and they say they want to be in a hospital, they want to participate in the process, but then you start orienting them while they're impaired to the restricted environment they're going to be in. And so sometimes we have people that come for the admission and then they leave.
Right.
Because after hearing what they're going to be a part of, it's not something that they want to do. So transportation from the rural areas to the facility has been the biggest challenge.
One of the projects that we're working on with HSD and the governor's office is on the super utilizer. And what we're finding is, a significant portion of super utilizers on the Medicaid side and Medicare are behavioral issues as well as substance abuse issues. And I know we're trying to partner with Christopher St. Vincent, and then we're also looking at this program up in Taos County. I guess it's the three-county one, Tri-County, I think is what they call themselves. And that might be one of the issues we can approach, and that would be in terms of how do you transport people before.
Because they're still a Medicaid recipient, so wouldn't they still be eligible for SafeRide?
Well, they would if they're Medicaid.
They are, but they're not an admitted patient at the time of the appointment. And I think the other piece is that a lot of the consumers that we have coming through our door have burned a lot of bridges with their natural support systems.
Oh, yeah.
So we've been trying to reach out to that piece, and that's been a tough one.
There is still a Greyhound between Las Cruces and Albuquerque and on.
They're Medicaid eligible generally, but not enrolled. And so
Oh,
we're
they're
also,
not enrolled yet.
You may want to talk, Sean, about the PE program.
Maybe that Greyhound would be a good.
So Mike and I have been talking about getting our admission staff certified in PROMOSA certification so that when they are coming in that we're able to assist them in that process. I think it's a tough one because some folks don't follow through with the pieces that they need to get eligible. So it's that whole part of not being able to kind of move someone from one process to the end and then be able to have that outcome. So that's something that Mike and I are looking at.
Right.
We have a facilitator that takes them all the way through, like a navigator, like a care navigator.
Yeah.
We
That'd be
used
nice.
to have those.
Come to your
Human
house,
service
get you out of
Yeah.
That's what we used to
Take
do.
you.
kinds of names
Today,
to
so
give
let's get
people.
out and get
That's a good
going.
question. That's a good question. So that's still a big challenge we have. Okay.
I wouldn't rule out the Greyhound.
We've been doing a better job of encouraging the folks to use the rail runner, and then picking up, the parent or the consumer and bringing them to the facility. So that's been something that we've been doing over the last 2 weeks, and it's been successful.
There's a lot of, I think, possibility to get the free passes. And then they can use those passes to get on the buses too. They don't have to pay for the buses if they have the rail pass. They can use those passes too.
And sometimes even you want to pay ahead because they'll go cash in their ticket for cash. So sometimes you have to work it even more than that, like where they can't do that where it has no cash value. Because I've bought people a bus ticket before, and by the time I get to my car, they're cashing it in and they're walking away with the money. I'm like, well, how are you going to go home now?
Well, we used to, back in the day, we had a really nice collaborative with the Value Auctions where at Valencia Counseling Services, we actually had the adult consumers had their own business called Reliable Rides. And so they were able to incorporate themselves as a business in addition to assisting with the transportation in the rural areas. And that got defunded, when Optum came on board. But I think that's a really creative way of, assisting people with employment. And it was something that was really successful in the rural areas for transportation. Even if you call Safe Ride, if they're late, you're 45 minutes behind your appointment. So it was a good program that I wish we could kind of
In
get
fact,
back.
I've got a veteran-owned business
Very good
down
program.
in Silver City that is looking at doing that model to try and do those types of contracts with the state. So,
Who would we connect with, maybe from your folks, to maybe do some more collaboration here?
myself or my deputy right
Okay.
now.
Okay,
Hopefully in a month I'll have a healthcare coordinator on board.
that'd be good.
Okay, great. Not somebody from DOH though.
I usually steal most of my people
Yeah.
from Workforce Solutions. So.
All right, okay.
We're safe.
Let me move.
Oh, my gosh.
Sure, go ahead, Rubianne.
Well, welcome aboard, Ms. Hartley.
Thank you.
When you had mentioned the 40 beds for the or the adults, that we have 40 bed capacity, is that 40 licensed beds or just?
By DHI, yes.
Okay, so you have 40 licensed.
We have 40 beds total, and then we have the capacity for 10 detox beds.
Right.
Because the detox and the rehab unit are in the same area, but we have the mechanics and the machines that we need for the detox process. So we have 40 beds total, and then we use those beds as we have detox versus rehab. So on average, we have about 34 in rehab each day, and we have between 4 and 6 in our detox program.
Okay. And great discussion. I know it probably got us a little behind schedule as a facilitator here, but our host today, John, you want to give us an update on how you're doing here?
Sure. Thank you, Brad. First, just in terms of number situation, we presently stand at 75 unduplicated individuals receiving services for us, and we presently have, I believe, 4 crisis referrals at present time, 2 on the healthcare side, 2 on the behavioral side, one of those being a potential 1.6, I believe, placement out of the Las Cruces area there in terms of numbers with us. One of the areas of emphasis this last quarter for us has been actually with the local law enforcement entities within the county, both in the Belen area and Los Lunas, where our staff, along with some individuals from APS, put together PowerPoint presentations and informational presentations on our population that we serve that are in these home areas here, our interactions with them, our emphasis on programmatically on de-escalating situations out in the community rather than physical type of interventions. That has been very well received, particularly over in the Belen area in terms of law enforcement there. And we are starting to see some results from that in some of the interactions with individuals we serve. On the Los Lunas side of it, maybe a little bit more difficult, but we're presently working through that, and we've been called upon to do some follow-up with Los Lunas. So we see that as positive just in our relationships overall with local law enforcement entities, but also how they provide services to the population that we serve. So a lot of pluses there, and we're very happy with that. We continue to work with, related to Los Lunas Training Center campus, with Department of Corrections on their proposed expansion. That has stopped and started a bit, but as they proceed, we are in their men's recovery program. In the last 2 years, that program has gone from a population of roughly 50. We're approaching 100 at present time, and they have identified their total number to be involved with that program at 150. that is raising infrastructure issues and those type of things that I don't think they were totally prepared for, but we were aware of, and we are starting to work through that. And Michael Brown's been very involved there with us on the DOH side of working through with that. Second side of the proposed expansion with Department of Corrections would be halfway houses set up in about 4 to 5 of the existing cottages on campus. That would be for a female population. Numbers wise, those were originally set up for roughly about 16 individuals. Corrections proposal identifies about 40 into those units. Now, how that's exactly going to happen, we shall see. But again, related issues to that we're working through with corrections. Don't know if we'll start to hit a tipping point of who has actual responsibility for Los Lunas Training Center campus in terms of who's occupying the space on that part. That again is a Michael Brown situation that he is looking at. If we would get some relief from that, that would be great for us on our end, Brad.
Right.
With it. Let's see, we continue again, a lot of involvement with Michael Brown's unit in Santa Fe regarding just multiple infrastructure and pool repair and those types of situations, and those continue with us, and we appreciate that. Right now, with the 25 or so leased residential homes in the county, we're going through the preparation for change of seasons with all that is included there with those. So we have that going on. We also had a company that goes by the initials of CERL Environmental that I think was contracted again on the Los Lunas Training Center campus. I believe they're just doing their study, environmental study, mostly related to issues of, I would say, radon, asbestos, those type of things, to see exactly what is at the training center campus. That was completed last week. We don't have any additional information on that at this point in time. The dental clinic that is under Los Lunas Training Center out of Albuquerque, that with Deputy Secretary Gallagher heading up our group there in attempts to get that staffed appropriately with the ups and downs it's had the last couple of years. We're probably at our high point at present time in terms of dental, in terms of actual dentist with the one DOH dentist, Dr. Ray Lyons, coming back full-time next week from some medical issues he had. But also we've been able to obtain a contract dentist with an appropriate background to serve this population that right now is at 2 days a week to give a bit of relief to existing dental services. Also in terms of related staff of hygienists, they're identified as office staff, but they're really dental assistants and dental hygienists. We have 3 of those 4 positions now filled and working on that 4th. Again, that is a high point for us, so hopefully we can impact that statewide dental situation related to the DD population there. Improved with the numbers with it. We are working in conjunction with Division of Health Improvement on some new protocols and 24-hour hotline numbers related to abuse, neglect, exploitation, not investigations, but the protocols related to the reporting of those incidents and the turnaround on Division of Health Improvement side in terms of their coverage. I think we're one of 4 test sites that we will run till probably the 1st of July, see how that new system is working, and then if it spreads out and is broadened out to the entire state with it. So that one's in process. We've been through our first round of the Jackson litigation, the Community Practices Review, which is an annual situation. our first round with the consumers that were reviewed at that point in time really identified no special or immediate situations related to services or care they were receiving. So we felt good about that. But as soon as one round finishes, the next starts to roll in. So I believe our next round is scheduled for July. And we should have about, I would say, somewhere between 12 to 15 individuals involved with that. So we'll see how our outcomes there. We are also scheduled actually next week, I believe, middle of next week, Tuesday, Wednesday, Thursday type of time frame for related to the Accreditation Commission. We're having two consultants in from California. One is the administrative person, and one is the programmatic individual to start to take a look at where we stand related to a national accreditation process. So we look at it as a pre-survey because the facilities here have never been nationally accredited. So it's both a pre-survey and kind of a gap analysis for us to see where our holes may be. One of the difficulties we've run into is the actual standards manual related to this accreditation process has been under revision for about the past 18 months. So it was actually just released to us on Tuesday of this week. And we have the consultants in next week, so we haven't been able to do a thorough review of those standards to see where we may be at related to changes or that part of it. We've been operating really under the developmental disabilities waiver standards in the past. Those are a fairly close match, but we know we're going to have some gaps. My feeling is that some will be, there's going to be some probably policy development situations over between now and when we get scheduled for the actual process. So I will identify the exit timeline for this pre-survey process out to the to this group.
Could it be next week?
Yes, it should be. I'm thinking it's probably going to be late Wednesday afternoon, more than likely. But when I get something a little more definite from the gentleman, the lead surveyor or lead consultant will be a gentleman named Fred Dominguez. We got with him through CARF offices out of Tucson. I believe he's had some involvement in the state of New Mexico in the past, so he should be fairly familiar with our populations and a bit with our systems, so that'll be a plus for us.
John, have you received a physical copy of the manual yet?
We just did Tuesday, so we'll be, and I think we actually also got an electronic that I think you were looking for, Steve.
Yeah.
So once it just slows just a bit, we'll start cranking those out for folks.
You think he's gonna be, he'll be on the ground at your place Wednesday?
That will be actually the later in the afternoon will be the exit time frame.
When is he
Wednesday is exit.
When is he gonna be on the ground to do the survey?
I believe we'll be getting them materials on Monday.
Okay.
I think they'll be doing some work off-site part of Monday. They'll probably get in here at some point Monday, but we don't have time. Their heavier day is going to be Tuesday for sure, and probably Wednesday morning. We're in process of identifying sites and schedules right now from what we have. We'll get that out.
One of us will probably be there.
Okay. And when we can be a little bit more definitive, we will deal with that. But
good.
It is scheduled.
Good work on that, John.
Thank you. I tried to push it back to next year, but although it is good for us in the sense that I believe it was brought up at LFC hearings maybe at some point last year, maybe in the spring or something, that I wanted to be able to identify heading in this year for sure where it stood.
Now
and
we've committed to carbon accreditation. That's really important.
So we've got that going on. And the additional items, we continue with our involvement with both Division of Health Improvement, Developmental Disability Supports Division in terms of both in a quasi-consultative nature on some issues that they may have question on, or how we operate here versus what's going on in the rest of the state. So all in all, staffing patterns for us, we have actually, January was a fairly tough month for us, but February, March, and April are shaping up pretty good in terms of new hires, new employee orientations, that part of it. I think financial folks should start, or have seen, start to see a drop in maybe some of our overtime costs. I think we're down about a third in those the last maybe 3 or 4 pay periods versus the low, high point or low point, whichever way you want to look, towards the end of last year. So all in all, we're feeling good about multiple items.
All right, thank you very much. The CARP accreditation, yeah, we're very excited about that. I'm glad you mentioned it.
Yeah, good.
You guys will be there next week.
Yeah.
Thank you. And Laura, I know you've talked a little bit about this already, but go ahead.
Okay. As you can see from the report, the census has been holding really steady around 125 for the last quarter. Today the census is 129, so we're fluctuating between 125 and 130 on an average. So we're really pleased with that. Some of the projects and stuff that we're working on, maintenance continues with rehabbing some of the rooms around the existing facility now, doing painting, doing putting in some new countertops and things like that. So we're just sprucing up the place a little bit, getting ready for survey. One of the bigger projects that we're looking at, and it's not really a big project, but we're doing some tile work and things like that, all in-house, is we're rehabbing the kitchen in the Alzheimer's unit currently. To install, we deliver the meals down there every day with one of those portable tables with the hot wells in it, and I can just see injuries happening. So we're going to install that permanently over there, and then work it around so that they have a really nice serving area for the residents and the staff, make it a little bit easier on them. So that's the big project we're working on now. The architects have moved their in-facility meeting from the 21st to the 22nd of April. And so they're coming down. We're still going forward with the plans and finalizing all the specialty programs and things like that. So they're going to be in-house to do that on the 22nd to look at that. I did go ahead and send another request for a conditional approval letter to the VA, just so that I can continue to be a thorn in their side. Good. So I met that April 15th deadline with all that new information. Basically, it was reprinting the stuff that we submitted last April to get on the conditional approval list last year. So we haven't heard anything from them, unfortunately. We do know that they read the emails because we did a receipt, so we know that they opened it and looked at it. But that's it so far. I'm very appreciative to the letters that have been sent from the Secretary and Secretary Hale and Secretary Ward to the VA. Of course, we haven't heard anything either. I don't know that you guys have to this date, but we continue to fight the good fight.
Right.
It was interesting, approximately at the same time we were preparing the letters, the National Association of State Veterans Homes was in the process of submitting a national letter to the VA and to the President to increase the funding for all the grant projects for the VA. Currently, I think there's like $495 million of projects on the list, on the Priority 1 list. And so we're asking for them to take a look at getting some of those projects funded even more. Usually they fund between $85 and $100 million each year for projects, with renovation and things, life safety issues taking first priority over any of the construction. So that's how we see our numbers keep shifting down, because every year when you get a VA survey, if you have a life safety issue and it has to be funded, then the VA looks at that and they fund those first. So so we just keep moving on that list, but we continue to process all that information with them. As you can see under the hiring, not doing quite as good as VHI in the numbers, but good for us, 7, 3, and 7 for the last quarter. We have we continue with looking at the process on the hiring. We do have a hiring committee that's in place. They meet weekly to review all of the packets and then push as a team, getting all the paperwork done so that we can expedite those things out of the facility. We're really seeing a good turnaround with that. So I'm very proud of the team on that.
Right.
What I did, I have set up some one-to-one meetings with all the new hires. I'm meeting with every single new hire one-to-one. at 1 month, 3 months, and 6 months after they start with the facility to find out how things are going, what are they encountering out there on the floor, if there's any issues. Everybody knows that what you get in NEO and then when you get to the floor is sometimes a little bit different. We don't want it to be that much different. We want it to be pretty consistent. So I'm meeting with the new staff to see, where they're at and things like that. So we're starting that. Survey and regulatory things. Fire marshal and the pharmacy board were both in the facility. It was a whirlwind. I mean, the fire marshal was there in the morning. I saw him briefly, and all of a sudden he was gone.
Troy, I'd like to have your fire marshal.
I bet. Yeah. Well, he cites everything that he tells you that might be an issue, but he does cite everything. So, well, that's okay. So we're in the process. We've done the plan of correction on that and sent it up to the fire marshal, and we're waiting for an interpretation on one issue, and we have not heard anything back on that. So we're, fixing things as we go forward, but I haven't heard anything else. Same way with the pharmacy. I sent you guys the note on the pharmacy board when he was there. He came in. I don't think he was there 30 minutes. He looked at the stuff in the pharmacy, didn't even exit with me, and told Greg, well, we'll see you next year. So I assume that's okay.
Sounds good.
So we haven't heard anything else. And then we're in our current window for CMS and VA, and Joint Commission doesn't come back to see us until 2016.
Good.
So we're doing everything around the facility like we always do, making sure that we're ready and getting things spruced up a little bit. Under miscellaneous, we had 6 members attend living in the union environment down in Las Cruces. I want to thank the team very much for providing some of those trainings down in Las Cruces. It really makes it a lot easier for us to attend. So I was able to take 6 members of my staff because it's only an hour down there and back. So not too bad. It was a very excellent presentation by Sandy Martinez. She's in the process of preparing another training for our investigation team. So we're looking forward to that. She said she would be back in the Las Cruces area too. So I'm very, very happy about that. And we'll be sending a team down for that. I have talked to George Richards. We have scheduled some time after July when he gets some of his other training squared away with DOH, and so he'll be preparing some supervisory training down at the facility for my staff that I asked for a little while ago. I'm in the process of reviewing our options for the laundry contract. As you can see on some of our numbers aren't as great as we would like them to be. We got hit with a 136% increase on our laundry services. So I'm in the process of looking at our options. We had to fund, of course, the contract now through June. So we have no money. There is no money. I can't do anything else for the rest of the fiscal year, so there's nothing else left. So we had to fund that contract because I have to have laundry services through June. I am hopeful that the information that I gather that we'll be prepared to go forward with something in July, one of the options that I have. So, sir.
Were you thinking of building your own? I know.
Yes, I am.
You have a building already.
We do have a building already. We were going to do a laundry in the new building for when the new building got on board anyway. And so we do have a metal building out there that I'm using for storage right now. But that's my plan, is to run the plumbing. It already has electrical and stuff. And then entering into a lease agreement with the equipment so that we don't have to do the maintenance and so forth on it. So I'll be looking at probably a couple staff members that I'll either take from existing staff or maybe 2 new positions in the new fiscal year or something like that to operate that.
I've done it both ways when I was in facilities, and what I found was the key thing was your manager.
Okay.
If you find somebody that knows the business, runs smooth.
Okay, perfect.
If it runs well, it's a lot better. You get a lot better product.
Oh, sure.
Because when you're getting stuff delivered, who knows what you're going to get, right?
Right. That's exactly.
If you can do it internally, it's great, but the manager's key.
Well, I may get with you and get some key pointers when I start to put some of this together, but
Okay.
that's my plan, to work on that over the next couple months so that I'll have everything ready to go in the new fiscal year so that we can get going, because I can't
That's
afford
incredible
this.
cost increase.
It's $500,000.
Yeah, they're
I
kind of
just-
holding you hostage right now.
It's.
What were you
that's-
using?
It's a local company.
I may have a vendor for you.
Okay.
I can do it cheaper than that in my facility, just start and it'd be worth the transportation.
Find a veteran-owned business that wants to do a
No, I can
laundry
see these
service.
snow days happening. No, that ain't gonna cut
We're getting a Humber.
it. Oh, sorry, I did not know that. Oh, well, true, but I could fly it. Back and forth, but
Drum. We'll get a drum.
I think I want to be prepared for the new buildings that we're going to get anyway, so I want to get everything done. I may as well just start a little earlier. So.
Is that going to be a capital thing for the laundry, or it's going to be internal?
It's going to be internal. Yeah, I mean, the equipment and stuff, I think we'll run it through a lease, so I don't have to worry about too much of that. I have a plumber and electrician on staff, so they'll run all the plumbing and the electrical. We can do the separation in the existing building now, so.
Well, we'll definitely make that a priority. We'll work closely
Yes,
with you.
yeah, that's why I'll be spending my next 2 months working on that. So
Astronomical, I get that word. It's,
Astronomical, yes. I was trying to be politically correct. Anyway, so Point Click Care, the training and the implementation is actually going extremely well at the facility. Our staff members are being trained. We have all the billing stuff done. They've been producing information. They pulled off a census, which is the first time they've ever been able to pull off a correct census all at one fell swoop with all the payers, why the number of days and so forth. And so the ASD staff were thrilled. It took them less than a minute to run this report, and they brought it to me and showed me all this. It was excellent, excellent,
That's
excellent.
fantastic.
So Maria's in charge of getting everybody lined out on the administrative aspects, and then my MDS coordinator is doing the medical aspects. So she's getting the docs and the nurses and stuff trained on the PCC. So we're thrilled about that. I have 2 speaking engagements later in May. I'm making a presentation at the Military Officers Association meeting down in Las Cruces. And for some strange reason, they asked me to be the keynote speaker of the graduating class for the high school.
Wow.
Yeah, I'm very honored. I'm very honored to be asked to do that. It's just interesting. So I'll be preparing a speech for that. And of course,
valedictorian?
I'm sorry?
Are you the valedictorian?
Am I the valedictorian? God, I hope not. No, my grades weren't that great when I went to high school, so I'm sure that's not happening.
But it's your high school.
It is my alma mater, yes.
Congratulations.
A few years late. So, yes, thank you. I was very pleased. And of course, last but not least, on a fun note, we're getting ready for the placement of the trophy that Jeremy's group is going to provide to the Veterans Home when we fight the fort for our weight loss challenge.
Second place.
What? No. Hey. Yeah, we're going to have to come up with something really good because we're going to get everybody else involved next year. So yeah, we'll do this again. So, and that's my report. So
That's great.
And on a
Okay.
light note.
Turf races.
Well,
Yes, we can.
Well, I'll focus on that laundry.
Yes, sir. Yes, I will be doing
I'll
that.
tell you.
All right.
Okay. Stand
Okay.
for any questions or anything?
Let's go. We got a little bit more. Marty, you do Roswell.
Okay. I'm sort of envious of Shauna's 7 weeks. I have about 7 days.
No, so yeah, you're in a learning
board.
curve.
But some good things are happening. We've had a pretty good hiring focus. When Brad and I talked before I started there, we talked about the need for staffing and just operational things. And so we've had 5, that includes me, in the last few weeks. I think they're listed on the report. Our finance person put this report together for me.
Right.
The 2 that I'm the most happy about, other than myself, is the counselor that we have gotten, the CDU counselor, with some real education and credentialing, because I am a little concerned about that side of the house. She has already started, met with her yesterday.
Good.
And the infection control practitioner that I know Dr. Torman will be very happy about, has all the right licensing, credentialing, experience, and she starts May 5th.
Excellent.
So I'm really happy
You know
about
what her
that.
first job's going to be, right? The plan.
Yeah, oh, I'm already looking at that.
Are you?
I just haven't had a chance to get back to you because I was gone for 2 weeks.
Okay, good.
But the other thing I might mention is that I'm just thrilled to have such a great HR team at our rehab center. I can't tell you how great they are and what they've been doing. The job fair went off wonderfully. All last week we had an open house. We've advertised. That's one of the deficits, I think, that the center hasn't been out there in the public's view. So we had a few every day, not hordes of people coming through, but they planned it for it to be all last week, so all this past week, and we had some really good turnout. So, and out of the job fair, we got 2 more very experienced, licensed people for our chemical dependency side.
There you go.
The only other new thing that I've been able to accomplish, since I'm still really in the weeds, is that I have a plan set up for both physicians. We're meeting daily until we start to see more progress.
That's where Dr. Dorman coming down there will be helpful as well.
It will be.
Because you have one position that you'll need Dr. Dorman's help with.
Yeah. Oh, I don't know. I think we're doing okay.
Excellent.
Love your help, but I think we're doing okay.
Good.
Meeting with her every day. I've had some heart-to-hearts, so I think we're headed in the right direction. So we're looking at the admission process. The two goals, I think, right now that we have are getting the right staffing, getting fiscally responsible processes going, because we have some that aren't so good. Our admission process, I'm looking at that and working with physicians on that.
Right.
And then the other thing is getting our staff where it should be.
Yeah, and our Santa Fe HR team, I know, is working real closely with you.
And Ilona and Teresa Padilla have been fabulous. There's a young lady that works with
Lisa?
them, Lisa. She's been down.
She dropped down there.
Yeah, we're going to have another conference call, I think, with you here next week.
That's correct.
So I'm just tickled pink with that. I hope I don't get slam dunked and get disappointed, because I'm just so happy with what's been happening.
Right.
I met with the union president because I had all this scuttlebutt going on. So was that Monday afternoon? I didn't even know it, but the union was having a meeting in Roswell on one of those afternoons and mornings. And when he was finished with that is when I had my meeting with him.
Right.
And I thought it was very productive.
Good.
So I'm not anticipating any union problems, and I know Ilona works quite closely with him.
Right.
But, so that's kind of where we are. We need a cultural change, but you know, it's a living, breathing organism, so we have to give it some TLC and a little oxygen now and then.
I think as I mentioned earlier, too, that week of May 5th to 9th, I'll
Yes.
spend a lot of time there. I think Dr. Dorman will as well, and Gail's
That'll be
going to
great.
pass it towards. So great. It's great to have you on board.
Thank you.
Thank you very, very much. I didn't leave you much time, Jeremy.
I'm going to do a very
There's
abbreviated
been a lot of great
version.
dialogue today, but
Well, first, yes, the challenge with NMSVH. I will make sure that trophy is bolted to our front lobby entrance so I can see.
Ain't happening.
Midnight, I'll see you over there with crowbars.
Yes.
Our census continues to creep up. This time last year, I think we were around 120. We're up close to 140 now. We had 19 admits and 13 discharges over the past quarter.
I'm real happy about that. I mean, that's great that your census is up.
And we have a target of 145 to 150, depending on acuity. We think we can keep the integrity of the quality of care at that level. We're just getting everybody else to believe in that. Yucca Lodge, the notable change was on January. We had to do a mass defection of pest control treatments and cleaning. We completely gutted the unit and got that up, so we're ramping back up on that. So that's why you saw the numbers rise back in February and March.
What'd you have?
Bed bugs, actually. Someone brought it in with their suitcases and whatnot. So we're trying to keep a little tighter control on our how we do the quarantine when they first come in.
It's hard.
Yeah, we learned a lot from that. So some notable things under our projects. We are in the preliminary final stages of our strategic planning to have our initial draft of that. I would have to give a lot of credit to Brad Isaacson and Mike Brown with GSD and DOH getting a lot of projects, making a lot of progress. It's been real productive the last few months in getting things done. And I'm interested in the May 15th. You can count us in for the leadership and management training. We've been actually meeting with George Richardson regarding to the leadership management training that we wanted to do down there at Fort Dare Medical Center. Point click care, yes, is going very well. I mean, our staff absolutely love it. Hires, we've had 17 hires. We're aggressively hiring right now. There's a host of HR events that we've been a part of. We're working at it from multiple angles. We have numerous initiatives around recruitment, retention, training, anything that we can do to help bolster quality staff. Our employee of the month, I give a lot of credit, Mike McCrae. He's one of our social workers. He's just excellent. We are in our survey window. We anticipate probably sometime next month. VA generally comes in around the same time each year in June. So we've been heavily focused on that right now. I mean, it's just been a complete blitzkrieg of preparation with that. We've also gotten we actually got the latest manuals on Joint Commission. So we've been using that as kind of like a mirroring thing so they can start looking at it from multiple angles since they're looking at that stuff anyway.
Right.
We have discovered some things. Not sure why this wasn't discovered in the past, but I'm always discovering something fun and new. And the fire doors we found in some of the units don't completely, there's a gap between them when they close, or they don't close all the way. So we're auditing our whole entire building on that. Got to give a lot of credit to the assistant administrator, Millage. He deconstructed the entire emergency response program that we had, and he's rebuilding that back up, and we did a complete walkthrough. We're going to then kind of ramp it up to actually have the actual drills, and we're going to do it multiples all the way through every shift. So 3 a.m. if I come in with some bloody shot eyes to some of these nations in line.
Jeremy, are you going to fix the doors? Are you going to install astragals on them, or what do you
Well, right now, I mean, they did try to temporarily, it looks like at some point, have that little, but they did not put any type of sweepers down below.
Oh.
So the smoke can come through that.
So you've got undercuts as well as gaps.
Yeah, and so
Wow.
I want to close all that up. So right
Is
now
that a
it's a tough part.
construction defect or?
Yeah, because it was never, I was told that in the past, our maintenance had put up those, they're like little stringers that are kind of overlap that are fire rated. But they don't cover effectively, in my opinion. So, but no one has ever, at least that in the survey, I was there last year, none of the surveyors caught any of that. I'm not saying that they weren't looking for any of that. I'm not saying with the recording session to go look at that. But,
through it.
but I mean, I can see right through the other side. I'm lucky because my medical equipment specialist, he was the ex-fire chief, and he for Santa Clara for 20 years. So he goes through and sees some things. And we've been without a safety officer for almost an entire year right now. And we've tried a number of different things, but we're now on the tail end. So we're actually hiring someone now. I think we have some really talented recruits to come in to really kind of.
That's good you caught that.
Yeah.
One thing I just want to mention that applies, CMS is on the cusp of approving NFPA 2012, which will be a huge progress. It's and the version they're on now is very old, as is the Joint Commission. We need to get copies of that, and I understand that requires a membership or something to get the NFPA regs. Do you know anything about that? Or?
Yeah, I can get that for you. Actually, when we were screening for our new occupational health and safety officer, that was one of the requirements we had in our interview process, is how familiar are they with the NFPA, with a host of other things. And we believe that one of the candidates we brought in, I'll get the resource and we'll have it sent up.
Great, thanks.
To you guys.
Jeremy, I'll probably just cut you short on some of the, you can just hit a couple of the high points with your report there, with the other pages, because they got us a little behind schedule there.
Yeah, there's only a couple more points I was going to point out here. We have, actually in our medical services, we've done an RFP. We've awarded a multi-year to a vendor, which I believe we've sent up to you, Brad, for signature. And so I guess it's in your court. I just want to make sure that we got everything in line.
I'll have to check, see that.
Okay. And also one of the things, we're trying to recruit talent. You know, we're always talking about nursing and practitioners always being short, especially in rural areas. We're now a part of the rotation for rural practitioners that actually do some of the residency in our facility in conjunction with HMS and I believe New Mexico University up here. So we actually are now going to have our second resident now rotating through.
So you have a graduate medical education program?
Yeah, they've worked that out. Well, we're just part of that circuit.
Yeah.
They come through HMS, but they have really, the guys that have come through so far really like it, and I think it really exposes them to, I mean, you make connections, you like to work with who you know. I think that really would help recruit to these areas. I encourage you to do it as many places as we can.
It's state-funded GME. It's not part of the federal Medicare GME. We invested state-funded GME dollars. So.
Right. Did you hear that, Dr. Dorman?
What's that?
Ruby Ann was just answering your question.
In New Mexico, we've invested state dollars, so we have some state-funded GME as opposed to the federal Medicare-funded GME, which of course, I assume you know is capped. So we've done some additional things so we can do some of this innovative work, so it's great.
Yeah, that's fantastic. I mean, I think I have always advocated for using residents, and unfortunately, in our state requirements for physicians, we actually exclude residents because they don't have the required minimum 2 years of post-licensure education. So I think we're almost killing ourselves, and we need to somehow work on that so we can accept these fresh residents coming out of training to work in our facilities. It's a huge resource. So I think there's a little bit of old thinking going on there. So I'd like to, I think it's a great resource, and I certainly advocate for residents anywhere we can get them.
Well, we're blasting through those walls. We do have, we do presentations on a number of different things, and whatever we can do to help support the community and get them educated. It's been a great, so far, a great program.
Good.
The last couple things that I have here, we are looking at several of our programs within the Fort Baird, and we're seeking to make noticeable improvements in those areas. So kind of like a deconstruction thing, so we get a 360 of what the whole thing are. We've been focusing on the CDU, we've been focusing on the therapy department right now. Nursing department has been an ongoing thing that we've going on. There's going to be a couple other departments that will also be big focus on, especially with the new IT projects we're looking at, that will help streamline and organize a number of those initiatives. Under infection control, we've had a couple of outbreaks, 2 different types of outbreaks actually, but I have to give a lot of credit to the response of the team. They were immediately responsive, and they quarantined those areas and really limited the amount of exposure and some of those agents were very infectious and completely minimized it compared to years past when the outbreaks have occurred. It was nowhere near that type of infection. So I got to give a lot of credit on the responsiveness, and they worked very closely with the epidemiology department and reporting that. So the other thing is our vaccination rates. We hold steady for employees at 93%, and our resident, I believe we got credit for being one of the highest vaccination rates in the state at 99%.
Yeah, you did.
So
Dr. Akista's been great, I know.
they've done a great job. The only other things I have to say is around the finance, we continue to work with around the Centennial Care Logistics. We're one of the facilities that have the lower reimbursement. We got our first payment, I think, recently, so we're hoping that will be like the little spike that now all the flood will come in.
I hope so.
But I know that the finance group, which with ASD has been right on top of it. There's been no lacking of organization and motive there. And we did get surveyed by the Board of Pharmacy who surveyed Yucca Lodge, and they gave us thumbs up, although there was a little confusion by the pharmacists that surveyed us, that after all the years that we've been under a hospital pharmacy license, that we suddenly needed to be a retail license. So we've just opted to go dual. And because after we sat there and talked with him for a while, he said, oh, no, you're licensed correctly. So it was kind of, anyway, that's a longer story, but we'll fix all that.
Okay, thanks, Jeremy.
Another revenue source.
There you go.
Yeah, maybe.
One question, has Dr. Shepard or any of the folks from Western contacted you guys about, they got funded the last 2 years for a PTSD pilot project. And we keep telling them they need to go through Department of Health, and if they're going to have a location, you guys would probably be one of the places to do it. I've never heard anything back from either legislative side or Dr. Shepard yet.
Dr. Shepard or Dr. Sherpa?
Dr. Shepard, the president of the university.
Okay.
He's the only one I've been in contact.
They have not reached out to us. We've had some community reach out to us for a different initiative, but during that discussion, something was brought out about PTSD.
We need to initiate that discussion, or?
That's what I'll double back with Representative Hamilton and They were trying to figure out where the money was actually going to flow through, because it's not going to flow through me. So it's one of the things that we'll try and work out.
Okay.
But again, if it's going to be a veterans pilot project, I keep telling them, well, we've got a veterans facility down there.
Okay.
So,
Okay.
Fantastic. I mean, we're all ears.
okay.
Well,
Hire any of our staff.
No. Okay, that was a very good discussion today. I know we ran a little bit longer on this part, but let me ask for a motion to approve all 7 administrator reports.
So moved.
Second? All in
Second.
favor? Okay, sorry, all in favor?
Aye.
Opposed? It passes unanimously. And Leonard, I haven't forgotten you there, but you have 2 things today. I know you want to give your finance report, and there's a resolution you need approval for.
Maybe we can start with the resolution. There's
Sure.
2 resolutions, and what they are, these are
Yeah.
depository accounts that
We have
we then need to have signers up in ASD to move the monies from
I'm not sure, do we have a copy of those, or?
Yes, sir.
It's in the back of your booklet.
the passed out, one for
Okay.
Truth and Consequences and the other for Las Vegas.
All right.
And the issue is that the signers that were on the accounts have moved on, or so we're needing to get this so that we can move the monies to the state fund from these accounts. So when they receive monies there, they deposit in here, and then we move it to the state
Oh, okay.
to the state fund investment pool.
All right.
So I don't know if we need two actions or one action for both.
Well, you can ask for a motion on both of them together if you like.
Okay, so there's for the Bank of the Southwest and Truth and Consequences, and for Las Vegas.
Community first. Community
So you're
first.
adding these individuals?
Yes,
Taking the
there's somebody there with signers, but those signers have all moved somewhere.
These are the updated names?
These are the updated names,
Okay.
and they're all in ASD.
I'll make a motion to accept.
Okay.
Second.
Okay, all in favor? Opposed? The motion passes unanimously on the resolutions.
So then we'll move to discuss the projection, the colorful paper, and what we have here, just for clarification, what we have here is the projection that we have after ASD and the facilities have met and discussed what has been sent up. And so what we're projecting right now is an excess of revenues over expenses of $1,038,000. So on 139 million, that's just a decimal point away from being an issue. And the reason that we submitted the second page, if you'll look at that, is this is a roll-up, or this is a breakout of the roll-up facilities that, at the facility level, the amounts that we think we are right now.
Is this going to be worked out by Gloria's laundry service?
I think that's why I'm so red.
But again, and we've had discussion with the folks in this room and also with the facility financial people. If you'll look at the projection related to the other revenues, which is our collections, you can see that we're flat compared to last year. And as we moved into Centennial Care, we obviously had some collection issues, but we accommodated that with the projection. But the questions we keep having is, are you seeing some expansion in the eligibility categories? And that's what we're not seeing. And the reason that this is an issue is for FY15, we have diminished the amount of general fund, and we increased the amount of collections because we believe we're going to see that expansion. So this is something we're going to be looking carefully at every week, as again we talk about that we're having discussions every week. Those have been helpful for several reasons. One of them is that are you seeing the expansion of covered eligibles for the under Centennial Care? And the answer so far has been no, but we're again looking at that. The weekly meetings, Mike leads those meetings that we have every week, have also been helpful because we're recognizing issues, and sometimes one of the facilities will fix the issue. One of the facilities, and PhD is also included. One of the facilities may fix an issue, and we'll be able to share information with all the others. So we think we're doing a good job in recognizing those that are eligible in resolving technical billing issues. And so we're again thinking that we have a concern that a year from now we may be sitting here and the whole thing may be in deficit. So we're going at this billing issues from several ways. One is to say, are we certain that we're billing for everything that we're able to? And that's again a benefit of having all the billing folks are there, and so there's a lot of cross-fertilization, lots of ideas to make sure that we're doing that.
Right.
Do we think our systems are up to snuff? PCC Care, I think, is going to be an improvement. Avatar, as we move forward, we're ensuring that it's doing all that it can for us. But we're going to have to, I think, my opinion, we're going to have to improve the billing systems, because I just don't think that we're going to see the increase in eligibilities of the eligible folks that we had hoped for. So that's kind of where we sit right now. I think this year we're going to be good, and we're going to spend a lot of time and energy to get as far as we can next year.
I think with some of the new systems that we're looking at may do a better job of scrubbing and make sure that we're optimizing revenue capture based on services we're providing.
So the system that Jeremy's speaking about is called SSI. It replaced a system called MedAsset. So SSI is not a brand new system, but what we hope is a better system. And what it does, it's not a billing system, but what it does, it takes the claims that we submit into it and it scrubs them, and it says there's general billing rules. You know, are you matching your ICD-9 code with your CPT codes? If you're not matched, then the payer is going to deny it. Are all the form locators filled out that need to have documentation? So yeah, SSI, I'd used it in the past when I was in the hospitals, and I found it to be a good program. So hopefully it'll limit denials, it'll improve the turnaround time.
Great.
If we're able to do that. So we've implemented that just recently. Yes, sir.
Sure, go ahead.
And probably it's going to warrant more conversation. And while we're riding the train, we could probably have more.
That's right.
But now your contracts with the MCOs, are they capitated?
No, they're fee
So
for
it's
service.
fee for service.
Fee for service.
With the MCOs.
Correct.
Okay. And then you have also dual. You're doing with Medicare.
Dual eligibles. Yes.
Yeah, as well. But the assumption is no private pay, or is that?
We have some.
It's minimal.
It's minimal.
It's very
So it's
low.
primary Medicare and Medicaid.
They're Medicaid,
And
some
VA for
commercial.
us. And VA for
And
us.
the VA, okay. See, my feeling is that the private sector
Right.
is also having the same issues you guys are going to be having. And we just lost the facility, and I don't know if that's associated with any of this, but in Hobbs, and then there's another one in Artesia that's at risk. And so I'm wondering if this whole issue will sort of,
Well,
how it's going to
we
affect.
think
So
that-
that's just my mindset.
The difference with us, and I think you all, the administrators can address this a lot better, is we serve a population that has nowhere else to do it in many cases. So I was on the private sector, and a lot of the lines of business that we address here, and that's why we have a general fund allocation. A lot of the lines of service aren't covered by any insurance company, aren't covered by MCO rules, so it is a state's desire to serve them, so we apply general funds to it. So we're in that crazy mix. Although as a division, we're I think about 60-40 general fund, or 40% general fund, 60% collections.
Right.
So we're highly dependent on our collections to
Right.
succeed.
And am I hearing you right? The Medicaid expansion was supposed to sort of target some of these folks that would kind of fall into the indigent category, and you're not necessarily seeing these folks.
We don't serve that population. Again, coming from a hospital environment, we were rejoicing this thing because a lot of people that hit our emergency room did not have coverage or now have coverage. We don't have emergency rooms. We're not that kind of business.
So as they come in,
They're the same folks that we saw before with the same coverage.
They just
The
have.
ones that were covered before are covered now. The ones that weren't covered before, is covered
And
now.
our revenue makers are the nursing homes, and so your nursing home population, we make sure we have coverage on them to bring them in. So there's going to be no extra revenue coming in on the nursing home side. There was a washout in the outpatient from indigent money. Now those individuals will be Medicaid eligible, so we'll see a wash. It'll be the same amount of net gross to us. Then you have the adult psych for us, which we were thinking could or may not have an increase in. What we're seeing is actually a decrease right now. Some of with the IMD exclusion criteria where the feds don't pay for that, it wasn't negotiated out with the MCOs through HSD, and so we're looking at them being real cautious or tight is a good way to say it in regards to what they're paying for. I'm over $1 million a month in indigent care and APD alone.
Is the reimbursement rates from each of the MCOs that you guys negotiated, is it different? Is it fluctuated or are they pretty consistent?
For much of it, we use the Medicaid rates. Although we did we get something on the long-term or what is it, high-low nursing?
The high-low nursing rates are established by HSD, so our contracts generally reflect those amounts, but those rates haven't been rebased in 5 or 6 years by now.
2007.
Yeah.
There's some fluctuation
7 years.
in the rates, but
Right.
I mean, I think we all feel. I mean, I wanted to go with the highest out of the three MCOs. We
tried
go
it.
for that. I mean, we tried that. I thought that was a good
Uniform rate.
The outpatient rates are pretty much the same.
But the rates we were getting were actually, when they rebased it, we were actually, from my understanding, we were gonna get, what they said that we should have was higher than what we actually ended up with. And with the negotiations with the MCOs, I think some of them they didn't wanna pay as high of a rate with some of the facilities. I think Fort Bear stayed flat.
We were flat.
Well, that's a good summary of the challenges, that we have. It is what it is.
Yeah. And we'll make the best of it.
Let me ask for a motion to approve the Program Area 6 quarterly financial statement.
So moved.
Second, all in favor?
Aye.
Opposed? Motion passes unanimously. Is there anything else, Leonard, you wanted to mention?
Yes.
It was all as it is. But we're working it. The most important thing is we've got
A lot of good
we're
folks.
working it real hard.
A lot of good folks.
Just want you to be first.
Okay. Then Dr. Dorman, we had a credentialing meeting yesterday in SLD in Albuquerque. I was there with you.
We had a credentialing meeting yesterday, and all of our providers that were applying for new appointments and reappointments were all approved for 2-year terms without stipulation. There were no questions or concerns about any of those providers, and we recommend from the Medical Executive Committee that the governing body approve the appointments and reappointments of all of those on the list.
All right, now I'll ask for a motion to approve the credentialing as a group as opposed to each one individually.
So moved.
Second. All in favor?
Aye.
Opposed? Motion passes unanimously. And Dr. Dorman, was there anything else? Did you have any?
No, just the update on, and this ties in with managed care. We're on the cusp, and I think we will be able to manage, if someone lights a few candles for us, to convince the managed care to deem our medical staff credentialing office to be delegated to do their credentialing. We've just got a few pieces in. I'm convinced that on the facility side, our files are already compliant and would be ready to go through an inspection by the MCOs if they desire to do that. We're just going to adopt Public Health Division because there's some work to be done, but Jose and Roswell is certainly qualified and capable, and he will be doing that starting tomorrow to get those documents in order. Another candle, please, for the receipt of the purchase order for Cactus Software. It's kind of there. I can see it, in the shimmering light. And as soon as we do that, we'll be having some training and education. We've identified Jose, myself, and we've identified an individual from Turquoise Lodge to know how to operate the software. It's always nice to be 3 deep in anything, so you didn't get real deep in anything. So Teresa Sanchez will be helping us with that, and we'll be doing the training at Turquoise Lodge. It'll be a web-based educational program sponsored by Cactus. And so that'll take a couple of days, and then we will be good to go. We will need to have our credentialing and privileging policy approved. I think that's, I don't know, do you know where that is, Gabby, right now? That
It's on my desk.
It's on your desk, okay. So we'll get that done. We sent it to them and they liked it, and, you know, it's a don't ask, don't tell a thing, but that's gonna be approved, and ultimately what we're gonna be looking at is hopefully getting delegated. As soon as we can stabilize it, we're going to seek NCQA certification of our medical staff office. We've got the manual on order. We're going to be working through it standard by standard. Jose and I are both very familiar with those standards, and we will be good to go, and we will have a credentialing office for the New Mexico Department of Health.
Wow, that's kind of impressive.
Thank you.
Sounded good.
It
does.
is.
I love it.
And it's true.
It's true, that even sounds better, you know.
Congratulations.
Great,
I
thanks.
can't
Well, thanks for all your hard work too, Dr. Norman, appreciate it very much. Well, with public or Ruby Ann, I always ask if do you have any questions on the laptop there, but,
Oh, not today.
okay. Ruby Ann?
I think that's it, thank you. Thank you all for sending minutes. Thank you all.
Okay, that was great, that was very thorough, very comprehensive discussion on a lot of topics today, so if there is nothing else, in terms of the next meeting, I guess, you know, I'm either looking at going south or north, I guess, so, you know, we're either looking at Fort Bayard, possibly, you know, in the summertime here.
Bring it on.
Good time to go there. So I think it's possible, depending on if anybody else has a different idea. It's a little hard for Lori, I know it's been hard for you to.
I don't have a room.
Don't have a room.
We can hang out with the
I
turtles.
want to go to TRC in the winter so we can soak.
Yeah.
Oh, I
That's
could,
right.
I could do a meeting down at the
Right
civic
now.
center. I could
Soak
borrow a
in the
room.
But in,
That's right.
in the fall or the
Would be at
winter,
the
she's the
facility.
one who goes to.
Well, maybe, tentatively, maybe we'll look at Fort Bayard. Jeremy, we'll look at Fort Bayard as for our next quarterly meeting. I know we went there last summer.
Yeah, July.
Yeah, we were there last year.
I'd love to have you come.
Well, LFC was down there last summer too.
I'll be a host and a guest.
All right, okay, all
Off work.
right. So I guess going back to Dr. Dorman again, I should, I think, yeah, I did that. We did a motion for credentialing and unity policies. So if there's not any other comments, I'm going to make a motion to adjourn, you know, from open session to closed executive session.
Make a motion.
Second, please?
Second.
Second, okay, all in favor?
Aye.
Aye.
All opposed? Motion passes unanimously.